also has shown both in the government and the private sector the outcomes we can produce. And another thing which other states or state officials are jealous about is the uh, complete coordination we have between the government and the private sector in all the academic activities or clinical activities or research activities which is related to maternal and child health. So I think we would have a rich experience of Dr. Sathya here, which she's going to share. And so I hand over the memento and I invite, I'm sorry, the mic to Dr. Uma, and I invite Dr. Sathya here first to sit here. After she introduces, maybe she can go to the podium. Thank you.
Good morning, all, and I welcome you for the NeoCORE. So it's very honor and privilege for me to introduce Sathya ma'am. So I'm proud to say that like I am her student. She has inspired not only me, she has inspired many people. Many have followed her footpath. So when ma'am joined soon after her master's in public health from John Hopkins. She joined Chengalpet Medical College. So that time we were all doing internship. So we never knew that something like bilirubin can be done for a jaundice baby. Even that much we did not know, even when we finished pediatric posting. So we used to come for rounds both in the morning and evening and be with ma'am only for the entire day. Whenever she is calling, like we'll be very enthusiastic and be with her. The NICU was very small at that time in Chengalpet Medical College. From there, like what the NICU right now, being a premier DM institute in Chengalpet, I think the whole credit will go to Sathya ma'am. Um, so, she has many awards. To name few, called Taylor Award from Department of Intern Health, John Hopkins University, USA. Best Oral Presentation Award at International Conference of Perinatal Medicine at Barcelona, Spain. Best Outgoing Student of 1992, ICH MMC. Lifetime Achievement Award, Tamil Nadu MGR Medical University. Best Doctor Award 2013, Government of Tamil Nadu. Academic Award, Indian Medical Association, Tamil Nadu. But these are only tip of icebergs of what ma'am is actually. So there are a lot of things which she has done to the community, and that was the innovations which she has done all are community oriented. In 2001, when we were doing residence. Junior resident in Jitmar, it came in Hindu paper, ma'am's innovation for a low cost incubator. We were all excited. So that time, like something news coming in a newspaper is so excited. I was really, we didn't have WhatsApp or other groups to share, but I was having a paper cut and showing to whomever is coming home, she's my ma'am, like that. So I feel very proud to be a student of her. And thank you, mom, for accepting to give the oration for NeoCORE. And it is a honor and privilege for us to have you here for the oration on cherishing 3 decades of neonatal care, a heartfelt gratitude. Thank you, ma'am. I call Sathya ma'am to come to the dais.
I invite Dr. Kumuda ma'am to honor Dr. Sathya Jeganathan ma'am with Ponadai, Oration Medal and a small bouquet. Thank you, ma'am. I request Dr. Sathya Jeganathan, ma'am, to initiate the oration ceremony.
எது forward போடணும்? ஆ? Respected teachers and my dear friends, I'm really privileged to be here, and I extend my sincere gratitude to the NeoCORE to inviting me for this presentation. But when Uma called me for this, I was thinking, I was working for a long time as a primary care neonatology, and NeoCORE is always a high-end research, and how the young students will receive this, I was just thinking. But then Uma insisted, so I'm just presenting whatever I learned from ISH, from all the seniors, and how the journey went through after I graduated from ISH. So ISH was the mecca of learning in pediatrics, and most of us had the opportunity to get graduated from there. And the doyens of pediatrics, Professor Achar, Professor Gopal Raju, and KK and Professor C. Thiringana Sambandam, they were the previous founders, and they were the main people who initially started pediatrics in Chennai. I do not have the picture of Professor who had been before, but I have only picture of Professor KG Kamala. She was the first pediatrician to undergo neonatal training, and she came back. And here, I'm very proud to say I was a student of Professor Dr. Gopal, and he taught us great organization skills, and my training under him taught me to manage small as well as big neonatal units. I would just like to say a small incident. When I was preparing for my PG, I was a special trainee in IOG, and in between resuscitation, I used to do some MCQs. To, so in that resuscitation kit, I had my MCQ book, and when I went to the NICU, sir called me and he wanted to check whether I have kept everything clean. But when he was about to open that book, I was scared because the MCQ book was within the resuscitation kit, and I was just looking at his face, how he is going to react. He just saw that, and then he told me, "Oh, you're preparing for your exam." I said, "All my friends have taken leave study holidays, and I'm working." He said, "Don't worry." He said, Newborns are all angels, and they will bless and they will protect always." So always I remember his words. Whenever any problem comes in my life, I think newborn should protect me. That's the initial start for me to think about taking neonatal career. The next person who really inspired me was Professor J.M. She was a popular community pediatrician and neonatologist, and I had the opportunity to work with her in newborn care in Kanchipuram district. And Kanchipuram district was the first peripheral hospital where newborn care was established. And after I finished my MD, I traveled with her in the train. I told her, "Madam, I now want to branch to neonatology." And but she said, "I want to learn more of ventilators." She said all neonatal problems start in the community, and if you tackle it well, you'll be more successful. And if you work in community neonatology, you will do more good. But I said, still, I want to learn ventilation. She said, just turning the knobs and looking at the baby is not going to help. So you have to really work on the preventive side so that no baby goes into the ventilator. So that I always remember about Madam's words. And Professor RSS, I have never worked with him, but I had a great deal of respect and words from my friends Sai Lakshmi and others. And Dr. Pushpa in ICH, she was a great clinician par excellence, and she was a role model for many of us. And she never talked much, just one nod this or one nod that side and a smile. With that, she will convey lot of meaning instead of telling lot of sentences. And one great thing that happened in our state is like 4 senior pediatricians from our state had the Australian Fellowship Exchange Program by the efforts of Professor Elizabeth John, and then they came back and they really moved neonatology to the next level. And under the guidance of all these eminent people, we were able to move into a super specialty. The next thing which happened in the community level was IMNC Nodal Center was started in 2008. And initially, SNCUs were started in 2010 and established. And from in Tamil Nadu, the SNCUs are really well established because of the hard work and the training that's happening in ICH and many offices. So for many, whenever you finish the course, the life has got different pathway. So some stay in ICH, some go abroad, some go to private. But when I finished, I was asking whether I should join the government service. And all my seniors said, you write the exam, you join. And then after I joined, I was posted in this small primary health center in Tevur. It is in Nagapattinam. And the small building which is behind, it's the only building in the whole village which has got a toilet. And all the rest of the village goes for open defecation. So I had to request the PWD, will you please repair it for me? But they said, now there is no funds. So then somehow I have to repair it myself, and I stayed in that place for 2 years. And the first building is the labor room. And though I was not much trained in obstetrics, the words, some of the words spread in the village, a lady doctor had come, and many people started coming for delivery. So I was not very confident, and I was telling the DD that I'm a pediatrician and I'm worried that I may not. But he said, no, once you join a PHC, you have to be a general doctor. So every day, morning, afternoon, night, there'll be one delivery. And if there is any birth asphyxia, then the pediatrician in the district will call me and he will scold why you didn't do properly. So it was a kind of a reverse role. And that PSC was prone for cyclone because it is in Nagapattinam block, and often we had our PSC was flooded, and for nearly 1.5 months there was no contact with the outside world. So we had to stay within the PSC and manage. And I thought because of the rain, not many people will come to the PSC, but they were all sent to the nearby school and the temple for shelter. So it was very close to the PSC, so we had more patients into the PSC. And our labor room cot was broken, so we had to hire a local carpenter, cut the trees and make the labor board. And after 1.5 months, we asked, and people were making their own innovative ways of surviving in that period. Some people were fishing in the water, and some were cutting the trees and selling. When I asked for electricity, the PWD team said, Madam, you live in a peculiar village. You have very innovative people. They have cut down all the electrical lines and they have separated the copper and other things. And some of them they have sold and they have made some pots and all. So it's very difficult for you to get electrical lines. So you have to complain to the police. But if I complain to the police, then I cannot live there. So somehow we managed for another 2 months till we get the electrical connection. So when so many deliveries are happening in the place, and there was a small room where I was having a neonatal corner and just covering the baby with the wool and cotton. And because Nagapattinam is close to Velangani, some of the visitors who came from abroad were also stranded. And one doctor from Italy, he just came there and he saw that, oh, you're doing such work in this small place. He said, I will recommend you to one of the Rotary team in our town, whether they can sponsor your travel and learn from our unit. So with that introduction, I had the opportunity to go to Milan, and I had the opportunity to get trained under Professor Minoli. She said we should never have neonatal units. Always we should have perinatal departments. And she said all pediatricians, neonatologists should learn obstetrics thoroughly, and all obstetricians should learn neonatology thoroughly. And she said, whenever you take the baby in the rounds, you should not take over in the neonatal unit. You should go to the labor room and take over the baby in utero. So that's how we should go. And I was really surprised by her enthusiasm and her charm. Any perinatal meet, she'll have a big smile, and because I'm used to having lot of, fighting with the OGCs, and she will smile at them. The moment she sees a OGCN, she'll hug them and she'll kiss them. But I've never seen that kind of relationship. But they said that's how the Italians behave, and. She was always smiling, and because of her charm, she used to have many fundraising events. And the neonatal department, she was not only building up the neonatal department, same time she was building up the obstetric unit. And she had many international conferences there, and it was an eye opener for me how a good human being can be a good clinician, and how you embrace all negativity and then make a positive one. So it was a learning experience for me. And from there, I went to John Hopkins University under Carl Taylor International. I was in international health, and Carl Taylor is a great humanitarian. He worked in India a long time and also in Nepal. And he said, nowadays your life is very easy. He said when he was young, to count mortality, his team will make him stand in the Ganges. A number of bodies that are floating in the Ganges, they will count and then they will report to the. So he said that that kind of epidemiology and mortality we were doing, but now your life is very easy. And then when he finished, I told him, he called the students and asked everyone what's their plan after the MPH. Many of them, they said they will stay back to do the PhD. And I told him I'll come back to the government service. And he asked, really, do you want to go to government service? I said yes. And then he said, I've seen people from Hopkins, they go back and they want to change the system. They dictate the officials and then they get into trouble, and then once within a year they go out of the system. He said, I hope the same thing will happen with you. I said, no, I will try my best. I will stick to the system, because government system is the one where the really poor people come. And he gave me the article about Abhay Bang, and he said, he's Abhay's mentor, Abhay and Rani Bang's mentor. He said, with lot of enthusiasm, they both came from Hopkins. They joined the government service. They had some fight and they left. He said, hope it doesn't happen with you. I said, I will try my best and I stay back. And then I came to Chengalpattu Medical College in 98. And I just try to implement problem solving, Delphi method, and participatory appraisal of the healthcare givers. So it was basically a rural based center, and though not many facilities, but there were 8,000 deliveries per year, and 24 primary health centers and 5 GH were referring patients. And we have only undergraduates, and there were no postgraduates, and we need lot of things. And at that time, I just analyzed what things we had. It was only 3 phototherapy units and 3 cradles. And so rest of the babies were with the mothers and they were on the mat. So with this, and we asked the nurses, out of 98 nurses, only 2 were willing to work in newborn, and only in the morning shift and afternoon, night, no nurse was posted in newborn at that time. And so those who were willing, I invited them for a meeting, and then we went to Mahabalipuram, and then I just asked them to do the problem analysis and what was the priorities we want to set. But they said we are only 3 people, and the problem is more. I think we cannot do anything. I said, okay, let's try. If we cannot do anything, then we will move out. So initially, they studied the last 3 months, like what are the deaths we had, and then how many nurses, doctors we need. But we didn't have anything. So first, we thought we'll just create a warm corner. So one of the electrician, he just put a bulb, and then the babies on the floor were brought up, and then some more corners were created. But then one night, about 6 babies died. So out of 3 nurses, Shanti, she said, ma'am, I will not work in your unit. It's very troublesome and I feel like crying all the time, and she left. So really, we have to manage somehow. So again, we discussed, and then we made some carpenters. We met them, and then we made wooden warmers, and we used them for some time. And after 6 months, we got some donation for 3 warmers from one of the NGOs. And we also made a cylinder was attached and a detachable trolley. And over 3 years, we were able to fairly create one unit. And but what happened in the villages, there were a lot of bad child rearing practices, especially applying cow dung to the umbilicus. And many within a month, we had 6 tetanus deaths. And birth asphyxia was high, so we had resuscitation workshops for the students and also PHC doctors. And there was no protocol, so we had to make a protocol. And reaching the community with the help of NGOs, where all the deaths were happening, we had many health education programs. And the situation analysis after 9 years, now we had a bigger ward, and Kumuda madam was with us when we moved to this ward, and we were happy at that time. And due to donation, some more equipments we received. But the main problem was all the time is oxygen. Every day morning, we will think how many babies need oxygen and how much cylinders we have. And it kept on that problem because more babies were referred to us, and the number of oxygen cylinders we had was less. So initially we had only a small B-type cylinder. To that, a bottle was connected, and then to one baby. And sometimes if there are 2 babies were there, we used to attach a prong and then give to 2 babies. Then gradually we shifted to more using more oxygen, and the manifold room by the obstetric unit was shared by us, but mostly all these big cylinders were to travel from Manali, but only at night. And there is only one theater technician. He'll be busy in the theater, and he won't be there to receive that. So to solve the problem again, the only option is with the nurses. They said, madam, we will learn how to use this. We will learn how to fix this. So all the nurses, doctors, including CRRA, we learned how to receive that and then fix this oxygen. Sometimes when we call the team, they'll say, your hospital has not paid the bill and today oxygen won't come. So at night, we used to go to the auto theater and then bring cylinders from there. I'm sure now postgraduates would have sued me, or they would complain about abuse, but that time PGs were very happy. They'll just come around and they will take a big trolley, they will take the oxygen cylinder, they'll bring, madam, oxygen alarm varadhukulla we will do it. So PGs and even grandfathers, many people, they were involved this. And this is Dr. Ravi Kumar. He knew everything about oxygen because he's more than the anesthetist. So even at night, I call him, he will come and then he will fix. He's none other than a professor of pediatrics. So he always tells me, Madam, even when you become a professor, you make me like a technician only. And, and the PGs, they used to make fun of me. Madam, you give us lot of work. We don't have time to read. We don't know whether we will pass MD exam, but next Olympic, when we go for weightlifting, we will definitely win because they used to carry all these big, big cylinders. And then, and sometimes when it's very difficult to get from the night, then with near the NICU itself, we moved, and then our nurses, they know how to use the emergencies. But then still, in spite of having a big manifold, we moved from small manifold to big manifold, from 20 to 40. But still, the problem was persisting. If there is one repair work in the oxygen, then the whole thing has to be shut down. And if 10 babies are on the oxygen therapy, and really we don't know where to shift those 10 babies. So again, we call the nurses, like how we can solve the problem. And the nurses, they really sat and they talked with the engineer. They said, like, we can have two kinds of set, and in between there can be a valve. So about 18 beds will have oxygen from the right side, another 18 beds from the left side. So anytime we can shut off the oxygen and we have 18 oxygen beds. So this is, I think it's a kind of, because we work there and then we suffer. So it's only we learn from the nurses how to do that. And always we think like, we always talk with the nurses. Every day we are thinking about oxygen, oxygen. I don't know when this problem will come to an end, but finally it came to an end when the COVID struck. So when there was a COVID problem, and so the collector, he asked like what to do. So now people said the main issue is oxygen and we need to have a liquid oxygen. So liquid oxygen, we got through the CSR. But what happened is, the collector called us and then he asked like, what do you need? And I think the collector, he read everything about oxygen therapy. And suddenly he posed a question to us, for so many babies being ventilated for so many hours, how much horsepower you need? But actually we never knew what is horsepower at that time. And then and then he said, "Oh, you are a pediatric professor and you don't know what is horsepower." Then after that, we went and learned what is that, because we need to talk to the administrators. So from then, whenever I went to meet the administrators, I took the anesthesia chief with me so that any question with oxygen he will answer. But we gave the budget for this, but after it was installed, we didn't put the budget for the connection line. So then again it was a problem. Then only Abad Bandhavar for everybody's Ekam Foundation. I called Sai really. So nearly now we have got 520 people in the COVID ward, and this has come, but there is no connection. But Sai said, "Madam, you just go ahead. I'll call somebody. I will not pay him. Within tonight he will do it." So that man, he came, he did not receive any money either from me or from Ekam or from the dean. Just by one word from Sai, he said, for her, I will do anything. And night, with the mask, nobody was willing to go to the COVID ward, but he went to the COVID ward and then he did the connection. And I would like to say, like, for nearly 10 years this was happening, but then when National Health Mission came into, like, all our life changed to better, and all nurses were trained in FBNC and SNCU were established, and ours was one of the 88 SNCUs, and lots of training were happening in our ICH, and Kumuda Madam, Vijay Kumar sir, and Srinivasan sir, everybody, they were involved in training nurses. So we had more than 630 nurses were trained. But our nurses, previously we had some money to go to Mahabalipuram and discuss, but then later our finance also came down. So always we go to a very nearby restaurant and then discuss how we are now when compared to previously. So these are the 4, 5 nurses, they always come and discuss, Madam, when compared to last 3 years, now we are now and where we should go before. But now then they said now we are a little bit okay, but people they have started going for many neonatology conferences, and they said, Madam, people they talk very high, but now still we are at a low level, always tackling hypoglycemia, sepsis, and oxygen, and so I don't know when we will go higher. But then we told them definitely when we persist, definitely there'll be an improvement in our center. And these nurses, they have a good habit of sharing. So every day morning breakfast when they come, they share the food of everybody's in one plate, and they will also discuss who's the mother who doesn't have food that day. So they will send to her some food. So every day nurses they will bring some extra food. And NNF conferences really opened up their vision because none of them had any. After attending the NNF, they'll come back and say, Madam, we had a conference in Singapore. We had a conference in Singapore. So they had an MOU with us, and the doctors from Singapore, they came and stayed with our team from morning till evening. Dr. Sam, he will come morning 8 until night 8 o'clock. He will sit with the team and they will teach how to start the IV line, how to put the plaster, how to cut the plaster, about nasal injury. And from Norway, there was a neonatal team visit, and they stayed with us for 1 month. So mainly from them, people learned how they were asking nurses, Madam, Namala, when a shift vanda we hand over, but these people, they stay, they just stare at the baby's lung. They just stare at the baby's lung. They said this is how they keep on staring, and then they change the ventilator dynamics. This is how it should be done. And and then they also had an exchange visit to Singapore, and then they saw how the labor room, they learned how the code blue was being done. And they said, Madam, the decision to delivery interval is less than 7 minutes. Just one meconium aspiration or one meconium stained liquor or fetal distress. Immediately, the mother is moved from one room to other room within 2 seconds, and the baby is out within the 7 minutes. And every day they audit how do they tackle that. And they came back and then said, we don't know, we can never reach this kind of standards. But then I said, like, we may not have a system like them. They have a code blue, but then how we can manage to attend a call from labor room. They said the time management is the issue. Sometimes we go too early, but the anesthetists are busy with the other cases, so we have to wait for a long time. Or sometimes we go late and we are not there to resuscitate the baby. So how do we manage this? So again, the answers came from the nursing team. They said we will have two lights in the NICU, and we will have two switches in the labor room. So if they think that they are going to do a procedure or shifting the patient, and we have some enough time, let them press the blue bell, so green bell, so that we can go slowly and we can attend. But in case if it's a fetal distress or if the baby is born and needing immediate resuscitation, let them press the red bell so that we have to run and reach there. So this is how we can modify the code blue in our institute. And because that's the time where we did not have postgraduates, so this is how the nurses themselves, they modified the system, what they learned in a foreign country to a smaller place. And they also taught the mothers feeding, and they also taught the mothers only if the ward is clean, you can go home early. So the grandmother, grandfather, they all get up early in the morning. They themselves will sweep the floor, they will clean, and they will clean the toilet, even they will clean. And they will ask the mothers to monitor. You just see three babies, and then they will say, SPO2, if 90 kilo vanda cholira அப்படின்னு சொல்லிட்டு she will keep on doing so many work. And then later, after that, after when Simong building was constructed, we had a larger space. So now we wanted to have a people in our unit, they had been exposed to Yamniku, so we wanted to have a similar one, but it is quite expensive. So what they thought, to have compartmentalized Yamniku is quite expensive, and we do not have nurses to monitor. So they modified a family-centered unit like this. So they'll have a privacy, but at the same time, the mother will have a bed, she will have a warmer, and also pulse oximeter. So here the father, the mother, and the baby can be together, and there is also provision for the grandmother to be with the family. and uh, and when gradually and then after about 15 years, like, we were able to get more equipments, either through CSR or through our insurance fund. And so at that time the nurse ratio did not change, so one nurse, she has to take care of many babies. But then how do they manage that? So one nurse, she'll say, like, just in front of my eye, my field of vision, I'll have two sick babies, two ventilated babies, and just in the periphery of my field of vision, I'll have CPAP babies who are okay, and the next two babies will be having Palade or two feet, which I can just instruct the mother and manage. So one nurse, she can manage 6 to 8 babies at that time. And uh, and then actually our team, we went to CMC Vellore to learn about whole body cooling. And Dr. Jana's team was kind enough to teach us the whole day. And then using phase changing material, initially we started whole body cooling. But then later we were able to buy Tecothamina unit, and also nitric oxide. So with all this, like, we were able to, from a small unit, babies lying on the floor, now we have got the equipment, machines, all high-end machines, and we apply to DM neonatology. And we also, the students were enrolled for that. But still, when we go to the periphery, we ask them, how do you feel? But one father was saying, I wish I was trained in KMC in the hospital to practice long hours, because the father said, you teach the family to do KMC, but you provide bed to the mothers. But for me, you ask me to stay all the time on the veranda and just tell me you do KMC. But I want to learn it under your guidance. Like the mother, if I lie down and have the baby on me, I'll have the feeling, and because now I'm not confident. What you teach in the what you did not teach in the hospital, now you're asking me to do at home. So I thought what the father said was true. So we created a father kangaroo ward with 6 beds where the fathers can also lie down. But at that time, some mothers were a bit apprehensive. One mother was saying, Ma, he's not okay. Even at home, he's not okay. How I can leave this small baby with him? Then we put a chair next, and then we told her, you just observe your husband. If he's doing okay, we will continue. So like that, then gradually the family dynamics changed. And then one of the fathers, he said, I come from work and you say we have to be clean. You provide toilet and bathrooms to the mothers, but why your gender bias? There is no toilet for there is no bathrooms for the fathers. Then again we approached CSR, and then we created a big dormitory, the upper floor for the men and the ground floor for the women visitors, where they can take shower and they can take care of the baby. And then for a long time, we were concentrating in the facility, and we thought the problems are still in the community. So we wanted to improve the continuum of care. So when Kumuda madam was the advisor, I was in Gandhigram, so I submitted a proposal to her to do a community kangaroo quality improvement project involving ACOM as a public-private model. And this is the effective KMC. So we thought the effective KMC practiced in the hospital itself was less, and then when they practice at home was still less. And so we invited Shashivani madam, and there was a meeting for all the district champions. And after that, there was a meeting in the district level. And we also went to the home and then asked the mothers, and we did in-depth interview. And when there was a focus group discussion with this ICDS workers, but most of them, they said, like, they were only shown KMC as a picture and they have never handled a baby, and they wanted more training. So the QA workshop and capacity building workshop in many places, and they were not very happy with the bags. Some of the mothers, they said it is very hot, And some said you give only a standard size bag. If the baby is too small, it's buried in that. If the baby grows, then it's not. So then 3 or 4 times with the ACOM, we got feedback from the mother. So we changed the material of the bag, the size of the bag, and the final model was made. And we made an intervention package for each district. But then once I went to the one village, and this one grandmother, she was sitting and she was hitting on the tamarind to take out the seeds, and there was a big noise, tock tock tock. And I asked her, "Why do you do that? A small baby is sleeping nearby. A NICU graduates was sleeping." Then she said, "Madam, there is a glass ward." I said, "What is glass ward?" Then she said, "It's called NICU." I said, "What is NICU?" And she said, "In that ward, my baby was there for 14 days. There the noise was more. There, the machines were making lot of noise, or people will make noise. And my little boy was not sleeping there. When compared to this noise, the noise in that NICU is very less. And now see how peacefully he's sleeping." So it was a kind of because we went as a quality improvement initiative in the community. But then when the grandmother talked to me, I said, like, we have to think of about our neuroprotective strategies, and so many we talk. But then when the grandmother talks, then she said, "It's so much light there, so much noise there. People talk loud. People come and do rounds." Then I was telling her, "Okay, we will try to improve," but she was not very comfortable. And the ICDS workers were talking to us. "You always talk about effective KMC, but all the IEC materials you have produced is only about KMC, benefits of KMC. Is there any material which shows that it has to be have more than 8 hours?" There is no such material for us to show. And they were also talking about father KMC again in the community. And this is one father. He lost a husband and he was very much depressed. And when the first time when he kept the baby on him, he started crying. He said, now I feel as if my wife is close to me." And he said, "Now I feel like both like a father and a mother." And he said, "I'm so thankful for this love." And gradually he started recovering from his depression. And he said, "Madam, you people always concentrate on mother KMC. I think you should give father KMC, because guys like us who are depressed, it really make us come out of the depression." And then from the feedback from the ICDS workers, mm, uh, the Gandhigram team, health education department, they created a poster for 8 hours KMC. And I just thankfully remember all the doyens who had really helped. But I would really want to tell about Dr. Sai Lakshmi. She's helped more than million vulnerable babies, and through her private-public partnership. And whatever is lacking in the government, we can just call her and she'll say, "Madam, don't worry, we can help you." And the bottlenecks when we started SNCU were constraint of trained manpower, legal issues to recruit nurses, because there was legal issues between government and private nurses was going on. And she did nurses recruitment, trained them, and also equipment maintenance. So 3,097 nurses in Tamil Nadu, and the same Tamil Nadu model is now being extended to Chhattisgarh. And the equipment in both the centers, Tamil Nadu and Chhattisgarh, the uptime from 2012, it was 16, it increased to 98.4. So she always says we work on complementing the government health system and not replacing it. And why ACOM model is successful? Because there's a strong presence, a need-based solution, and always Sai goes and discusses with the higher officials. She makes the permission, and to get the permission, she used to sit even 8 hours, 10 hours in front of the government office. But she will always do it with a smile. She never complained. And I would just like to, last slide about Muthulakshmi Reddy. I just want you to just go through this. This is about 100 years before. She was the one who really led the women to enter into the medicine field. And 0 to 8 years, the married women in Madras presidency at that time was 2,369, and the widowed were 1,316. So with the dismal statistics, she had to really fight with the system, and she had to change. And when she wanted to go to the school, all the school teachers, including the principal, resigned from the school because a girl visiting a school is a big pollution. So gradually, when she went after, the Pudukkottai Maharaja recommended her to enter the school, but even she got the first rank in whole of Tamil Nadu. But when she went to medicine, even the British doctor said they won't do rounds with the girl. So with that kind of tenacity, she really worked hard, and then she collected all the data, and with the data, she worked with the government, and even the government and the system was opposed to her, and then she changed the system gradually, and now all women doctors and nurses, we are all here because she was the first step she took, braving all the difficulties. And we had the medical legal issues. So when we had oxygen in that state, like one baby had a ROP, but that mother, she didn't come to us for follow-up. But then when she went to a corporate hospital,